You don't work.
With computer audio and mute yourself.
Hey, Jules, I see you.
Fuck are you?
Can you hear? Yes. Can you hear? No, it hasn't started yet.
That's what I thought. Waiting.
Oh, you went.
No, just listening to yours. I'm not on it. 'Cause I don't know if I'm gonna stay. The whole thing. Oh. Do you guys want to hear something?
Yeah.
Sure.
Okay, good afternoon, folks. Maybe Lillian, can I get a thumbs up from you if the sound's okay? Sounds okay. Okay, good afternoon, folks. It's Bruce Squires. For those of you who didn't join us last week and I haven't had an opportunity to meet, I am president of McMaster Children's Hospital, VP of Women's and Children's Health. So thanks very much to all of you for joining our second town hall. And again, I'll call it a COVID town hall. The purpose of this, just to remind folks, is it is an opportunity for us for me to share some information.
I don't know.
Ideally supporting all of the information that's already been provided through the hub and through regular emails that you've been receiving, hopefully, and having chances to review. So in sense, it's a supplement and a support, an opportunity for us to share some specific information to our portfolio, and most importantly, an opportunity to provide a forum for questions. Like I said, this is the second meeting. We did send out a survey after the last meeting. So in the spirit of kind of feedback and continuous learning, 80% of the about 30% of people who responded to the survey said it was valuable. So that's one reason why we went again. This will be our second one. So we'll send you another survey, and you can tell us whether after that survey whether it's valuable as well. We did hear that we should post the recording. Which I think is a great idea to ensure that others who can't participate right now can have an opportunity to listen and learn. And that was our intention. I just screwed up the recording in the first time. So we're recording now, and hopefully, as long as I don't mess it up, we're going to post this link for folks to review. Also talked about and keenness to post the responses. You may or may not have had a
Okay, so that's the last of the recs then. All right. Do you want me to bring the cassettes over here, or what we should?
I'm just gonna mute that.
Okay. Okay.
So we don't hear any patient information there. In terms of all the questions that came in, again, thank you so much to folks for sending in so many questions. We shared answers to many of them, particularly in a grouped form, in the newsletter that went out today. And we'll be doing that each week. But we're also going to do our best to provide specific answers to every question. We're a little bit behind. And what we'll do is we'll link that so that we won't be able to put everyone in the newsletter, but there'll be a link so that we can go and you can see every single answer. And where we have an email, we'll try and send it back to you by email. I also heard provide more time for questions. So I'm going to try and limit my my opening comments, balancing that with a couple of comments that said share a bit of information. And that is the last kind of feedback loop. I actually had a couple of comments saying, you know, you haven't really talked to us as a group, Bruce. Many of us don't know who the heck you are. So can you take a few minutes to tell us who you are? So I am going to start there. and I'll try and be real quick, but I appreciate this. I'd always looked to have the opportunity for a town hall, but we hadn't been able to set it up. So for folks that that might not know, I had the pleasure to follow Peter Fitzgerald and join the organization back in July of last year. And I came from CHEO in Ottawa, so one of our sister children's hospitals. At CHEO, I was one of the vice presidents, and my responsibility areas were safety, staff and provider, as well as patient safety. They were quality and quality improvement, HR, so I was responsible for the people side, communications, strategy, development, and deployment across the organization, governance, a few other areas. I'm not a clinician. Background has been in healthcare management and leadership for, it's coming on 30 years almost now. So feeling a bit old. In terms of kind of who I am, I'm lucky enough to have a beautiful family, wife and 3 kids. I have teenagers now as of the end of January. So I have a 13-year-old, a 15-year-old, and a 17-year-old. And so because of, in particular, the 17-year-old who was in his last year of high school, my family didn't come with me initially when I came to Hamilton. And so for most of the past 8 months, I've been on weekends, been a commuter back to Ottawa to spend time with my family, so that the grade 12er could finish high school and then the family would move. Obviously now for the last about 5 weeks, I've been a truly absent parent by virtual means only, spending time with my family, staying in a little small apartment with a young family here in Hamilton. So that's a lot about me. I would say I'm a heavy, not heavy, but I'm a big fan of kind of outdoor activities and sports. And so if anybody ever wants to go for a run, I'd love to join you. Right now it has to be far apart, but when we get back to being able to distance closer, I'd love to do that. One more thing, I will share, had a question about sort of vision for the organization, and I really appreciate that opportunity to just quickly share that with folks. You know, we as an institution in Ontario are truly a leader when it comes to maternal, newborn, child, and youth health. It's not maybe as recognized as it should be outside of or in some venues. And so a big part of my vision is to help us to build on and really amplify the excellence and success that we already have, that's anchored in a fact that we're a safety first hospital, safer together. We really are a leader in terms of patient and staff safety, and we've connected that with our quality improvement efforts. And the first piece of quality improvement is safety. It's one of the dimensions, but it's where we start. So we've got such a strong place to build there, but we can continue to enhance that. And so that's really the internal focus, is building on our quality and safety improvement. As I kind of look outside, I mentioned that, you know, we truly are a leader in terms of maternal, newborn, child, and youth health. And so we're in such a great position to really lead this region. And by region, I really do mean half of the west of Ontario defined in the new Ontario structure. We're really kind of one of 4 anchoring institutions for the province in terms of creating a more integrated maternal, newborn, child, and youth health system. And so it's not just about what we provide here, but it's about how we enable great care and great health throughout the community for the close to 500,000 kids and 2.3 million people in whole that we serve as an organization. And recognize that as we do those things and we build that stronger and excellence-based maternal, newborn, child, and youth health system in this region, we establish a reputation for being an anchor, being a leader, being excellent. As we build that reputation internally and then externally, that allows us to really to drive better decisions at the provincial level about how to support care for kids, moms, children, and youth, and how to fund it. So better decisions by policymakers, by politicians. It also allows us to leverage that reputation about being a center of excellence to gather support from the community. Support from the community just in terms of goodwill, but certainly as well in terms of philanthropy. And so, as we look back, if I can just kind of sum that up, by our continued laser-like focus on safety and quality improvements using CQI, and us bringing that to the notion of creating an integrated, well-served maternal, newborn, child, and youth health system for the region around which we're an anchor, we're going to be able to leverage that recognition, reputation, and acknowledgement to drive better decisions in the interest of kids and families, and better funding to allow us to deliver. So that's sort of a kind of a summary on where we're going. So I hope that's I don't know, of interest, and I hope it generates discussion around our long-term vision. Let me move real quick to a couple more updates. So PPE, lots of questions on PPE. I think some of which came in before we had finished last week's teleconference or video conference and before the announcements were made. And so I want to summarize, as you folks will know, we have moved to universal masking in all patient-facing areas. So where there are interactions with patients, then we will work with universal masking. The type of masking depends upon the location or the setting, and so if there's I'm not going to go into that now, but urge you first to ask questions of your leaders around the nature of that, and if you're not able to get answers, or if they need to escalate, then that will happen. In terms of administration, to summarize, we haven't moved to masking in those areas. First of all, we should be looking at where it's possible to work from home. So I'd encourage you to ask those questions to your leaders and to your managers about when and if to work from home. Again, in my view, we're driving to that first. Where there are the necessities to be present, it's vitally important that we model and live social distancing, physical distancing. That secondly, and perhaps it should be first, that we're always washing our hands. All our IP folks will tell us washing hands and cleaning surfaces is so important. However, you can wear a mask from home, cloth or paper, and obviously in society, if that is what you choose in working in an administrative area. Our allocation of PPE continues to be impacted by both best advice on safety and on the fact that we're in conservation mode. So I'll address a couple more kind of specific questions as I walk through, but I wanted to kind of frame it around there. In terms of the other update I wanted to give, relates to what we've called surge planning, which is really kind of what are we doing about the anticipated significant demand on the hospital system from COVID, and particularly from patients who may become infected and require care. So we have prepped for a significant demand. In the pediatric side, you will have seen, many folks will have seen that we have moved several of our patient areas. So the eating disorders program has moved down into the 1G space on the first floor. We've then taken our complex care population from 3Z and moved them over to 3B1. What that's done is created significant capacity in 3C, additional capacity to allow us to care for COVID positive pediatric patients should they arise. What we've also done is prepped the 4X area, which is the endoscopy unit, so that if we needed that additional capacity, it's another 20 beds that will be available. On current projections, that would not be anticipated until well into any surge in demand. We've also prepped and are continuing to prep the site so that we could care for adult patients if there is a need for that capacity, because we're stretched at the other HHS hospitals. What that looks like is this weekend, starting tomorrow, we will be moving the 4B1 clinic to 2F. That will then create some capacity such that when necessary, we will decant our women's patients into 4B, and then 4C would be available for women's health. We would also have capacity created in 2P, and folks may know that's already been made available, as well as in same-day surgery. So all of this has been about ensuring that the health system has capacity should there be significant requirements for acute care and for ICU space for those infected with COVID, while also caring for our existing population. So far, social distancing and other things have meant that we have not seen the kind of demand on the hospital system in Ontario or in Hamilton that we had, if I can say frankly, that we had feared, and that was modeled based on some other jurisdictions. That doesn't mean that it might still not occur, and so these preparations continue. We just know that right now we are doing well, and so it's vital that we continue our efforts with respect to social distancing, physical distancing, and as a hospital to ensuring that we have the capacity to care for and treat these patients. I can't really go on without acknowledging, of course, the challenges that are being experienced in long-term care and in residential care settings, both in Hamilton and other parts of the province. So that is of significant concern and a challenge. And HHS has reached out to help, and so we can expect to hear more there. So that's really as far as I was going to go on sort of the what I was going to cover. So now I'm going to turn to some questions, and I'm going to look to in the next 15 minutes get through as many questions as I can, because that was a little bit of the feedback that we received. So let's go. So one of the questions was just wondering if nurse managers and nurses on project work will be considered to help out frontline nurses, thinking it will help with strain on staff. And the answer to that is absolutely, and I wouldn't limit it to nurses, although I would certainly acknowledge that, but I would suggest that, that all of us have recognized that we might be asked to take a different approach and take a different role. One of these times where I wish I had a little bit of a clinical background so I could at least help in a more meaningful way myself, but I can do things like screening that frees up others. So the answer to that is absolutely. The possibility is held out that we would ask folks to take on different roles to meet the need. I would really take a moment to acknowledge the number of folks that have stepped up to exactly do that. Please ask me to do whatever I can. As it stands right now, we have not had to do as much redeployment as we thought might be required, but that continues to be a possibility. I'm going to go to the next question. So, and all of these start with hi, Bruce, which is really nice, really friendly. So some of my staff are concerned about leaving their mask in a plastic container, as that seems to be a good place for viruses and bacteria to grow. Thus, anything that may be on the mask will grow and multiply while in the container. They're cleaning their containers between uses, but still fear anything that may grow while in the container. Can you please comment on this? So as you might expect, we asked an expert to answer that, not myself. Because it's for a short duration, i.e. for breaks, there's not enough time for anything to grow in a container when we are doing this process of extended use through the day. We are only using the containers for the duration of the shift, and the mask would be discarded at the end of the shift. Therefore, it would not be an issue. So thanks very much to Andrea for providing the answer. Another question we received, and I really like this, any thoughts, advice on skin breakdown due to universal masking? So again, went to the expert. And so Stephanie Furtado, who's our skin wound and ostomy nurse clinician, has provided an answer. And she's noted that the nurses specialized in wound ostomy and continence Canada have recently produced a best practice document. And we'll share the link, but it highlights moisture application at home before coming to work. And if skin breakdown occurs, to use hydrocolloid dressings, and at MCH, that's the Tegaderm hydrocolloid or Duoderm foam, and also the foam dressing would be the Meplix Light without border. So hopefully I said that okay, but we'll post a link for that question around protecting your skin from extended use. Again, a couple of these are on PPE, and I really do want to cover them. So it's been publicized that that N96 masks are being manufactured in Ontario. When will we be provided with this new PPE and fit tested for it? So we haven't been allocated those masks here at HHS, but we have been getting the additional masking for N95. So we will go there first. Again, I'd encourage us to look daily at the dashboard, which is giving us a sense of frequency of use. If and when we move to another masking approach or a different type of mask, then fit testing will be done. Is there a science behind the one mask per shift? And yes, there is. So CDC has provided this guidance around the kind of the evidence associated with use. The maximum length of continuous use in non-dusty healthcare workplaces is typically dictated by hygienic concerns or practical considerations rather than a predetermined number of hours. I'm going to move to a couple of other questions. Would it not be better to open one COVID-19 hospital instead of having units in all hospitals to help to stop the spread within each hospital? And so the individual had been listening to an Italian physician on CBC radio and commented on that being one of their biggest mistakes. That really is a good question and something that we're wrestling with. Again, it's a balance, because let's look at the Children's Hospital in particular. So the Children's Hospital has, we absolutely are a regional program. We have a number of specified areas, including in women's health. So the challenge for many of the HHS hospitals is if we were, for example, to designate Hamilton General as the COVID positive hospital and not have the Juravinski Cancer Center as have it as COVID negative, well, what happens for a patient who requires specialized cancer care but is COVID positive? So we've got that balance around how do we provide very highly specialized and critical care to a COVID positive patient if we want to keep that hospital COVID negative. And so what that's meant is we've started out by looking to be cohorting units. Units in terms of both COVID positive, COVID suspected, and COVID clean, particularly for those units that are immunocompromised. I suspect this will be an ongoing question, so I invite folks to talk about it and think about it. So it is a really good question. We've had my clinic may be moving, but there may not be room for me. If there's nowhere for me to be redeployed, will I still be paid or forced to take vacation or unpaid time? So I've clarified this. So for full-timers, absolutely. You continue to be paid. If you are forced to be redeployed, if you are not able to work, if you are isolated in relation to COVID-19. For part-timers, you also continue to be paid according to your scheduled shifts for that period. So the answer is yes. Another question, and I was struck by this one. Why self-assessment? It's very insulting. Anyone can lie about it. Waste of our time, and you're paying 4+ people per shift. Waste of money. And you know, I appreciate and respect that opinion, and I can see that perspective. We certainly did this carefully. What we've heard in terms of best practice from other institutions and organizations is that there is a benefit to the notion of employee screening and the approach that we're taking to it. It ensures and drives through a step-by-step questionnaire process a diligent look at where do I stand today. It allows folks to have real-time access to the current advice around what are the best screening questions to use internally to think about, is it safe for me to come to work? And it provides a level of kind of understanding and process, and to some extent some confidence for your colleagues. And so we've tried to do this in a way that moves as smoothly as possible, and big credit to all of you and to the screeners. And we tried to do it as respectfully as possible. So that's why that decision has been made. I can appreciate the kind of the contrary perspective and value it, and all I can do is explain why we've taken the approach that we have. Someone asked a question about carpooling. Can I still carpool with one person? And you know, what can I say there except that would recommend against any situation where you are sitting or standing with someone without the recommended social distancing. So that's a recommendation. Recognize that there are situations where that may become impossible, and so you kind of need to deal with those on a one-by-one basis. Urge you to do everything that you can to try and protect yourself. That, as we know, other parts of this are around frequent hand washing, around where possible using your own mask, coughing into sleeves, wiping surfaces before and after you touch them. So many other things you can do. On balance, if it's possible not to carpool, then we would suggest that during this time period. Had a question about, I'm just going to check our time, we're running close. Let me just do a couple of more here. Thank you for this opportunity. What are we doing to assure staff within the hospital are doing social distancing? And what are we doing to care for staff? Social distancing. I think we've made great efforts across the organization, and we should continue these to kind of provide demarcations to help you to do social distancing. There's kind of lines of tape for those who need to use the cafeteria. But the fact is we won't be able to do it in every single place, so a lot of it comes back to us. That's about us enforcing it, us being willing to say, okay, sorry, I need to step back a bit from you. I want to maintain social distancing while we talk. It's about us being willing to say, sorry, there's 2 of us on the elevator already. Can you wait for the next one? Choosing to take the stairs. So I kind of ask all of us to look at how we can help to reinforce social distancing while we are also providing suggestions to the organization. Support for staff. I want to point you again to the hub and the reference to the resilience support that's very extensively described there. Here at the MUMC site, on Monday, we will be opening a respite space up in the yellow section, Ronald McDonald House. And so where you need it, that respite space will be available. Of course, only so many folks can use it at a time. So we ask you to try and find, to use it, and then to vacate after a period of time so that others can as well. And so we're going to start off trying with that. As a closing piece, I just remembered another question around, I want to get changed. I want to make sure that folks know that downstairs, on the first floor, the locker rooms are available for folks to change. The showers are being kind of gussied up a bit more in case you want to shower. That is available, and we're going to continue to work. As I close, I want to do one thing. I want to have a quick little celebration as we come to the end. And so the way for me to celebrate is I'm going to read you a letter that we received today that honestly kind of brought tears to my eyes. So I'm not going to read the whole thing, but here's a key part. And this is from Ms. Nancy Ruth. She said, my 91 days at McMaster were under the oversight of wonderful Dr. Scatallon and her team, and consultation by many others. I owe thanks to so many: 34 nurses plus clerical staff in women's health, several surgical nurses, 3 IV nurses, 22 gynecology team physicians, 5 from plastic surgery, a general surgeon, anesthetist, an intensivist, an infectious disease specialist, a technologist, and 3 physicians in radiology, a pharmacist, 2 physiotherapists, 1 occupational therapist, respiratory technologist, a dietitian, and a social worker. 8 environmental associates looked after my rooms and the wards. 10 people from nutrition services delivered my food and took meal orders. I saw many people regularly and knew their names. They were a comforting network of hospital friends. Porters transported me and countless items around the hospital. Behind the scenes, lab technologists and assistants processed specimens, provided test results to guide physicians in my treatment, and matched blood for transfusion. I envisioned dozens more in facilities, administration, information technology, business, management, and other services essential to operations in my own care. Healthcare is only as good as the people delivering it. I received extraordinary care from extraordinary people. I'm grateful to everyone. So I'd ask you to take that as a recognition and a reflection of the support that society provides, and of the excellence of the work that all of you do in the interests of the patients and families we serve and of each other. If I had a bit more time, I would ask you to take an opportunity to pause, reset, and nurture. So I'm going to encourage you to do that. That's really about squaring ourselves and maybe taking a deep breath. Before we do that, I'm going to draw 3 more cards for quick little gift cards. So Mohammed El Torki is one.
Oh, amazing. Thanks.
Darn, no name on this one. So no name on that one. Jennifer Bell is the second. Congrats, Jennifer. And one more here. Sorry, Sarah Kirkwood is a third. So thank you to all 3 of you, or congratulations, you've won a small little gift basket. We're going to close off now. Thanks very much, everyone, for joining. I hope everyone has a great day. And again, please take back to your families our appreciation and thanks for their support to you and really to society. That would be my closing message for today. Thanks very much, everybody. Have a great day.